Hi there, my name's Charlotte Sharp. I'm a consultant rheumatologist based in Manchester. I'm a health services researcher with a big interest in how we communicate with patients. I was really lucky to be awarded this BSR Advanced Clinical Research Fellowship around 3 years ago now, and have been really delighted to now be able to present the resources that we've developed along with patients and healthcare professionals and the entire multidisciplinary team to help people to get started in writing their clinic letters directly to patients. So I first became aware of this as a kind of concept in 2019. I saw one of our rheumatology colleagues posting on what was then Twitter about the Academy of Medical Royal College's guidance, which came out in 2018, which is entitled Please Write to Me. The guidance basically suggests that we should write our clinic letters directly to patients and copy them into GPs and other healthcare professionals, kind of flipping the traditional approach where you write the letter to the GP and may or may not copy the patient in. I started to do that during my registrar training. I found that it really made me think differently about how I speak to patients in the consultation and in how I try and communicate in the written letter, and have been doing it ever since. I think it's really important to write to patients for a lot of different reasons. From the research that we've done, patients really appreciate being written to directly because it makes them feel much more included in the consultation and in the decision making, instead of two clinicians having a conversation about a patient where they're not included and they might not understand the words being used. When the letter is written to the patient, they're automatically much more engaged in that conversation, as well as engaging the patient outside of the clinic room. From my own practice, and we also found this from people that we've interviewed and people that have changed their practice as a result of hearing about this work, that it also has an impact on how you relate to the patient during the consultation. It makes it a much more shared process because if you then need to write in your clinical summary, we discussed different treatment options, A, B, and C, it's then really important that you have actually discussed them and you haven't just told the patient that they should increase their methotrexate dose, for example. So I think it can really be helpful in trying to shift from more old-fashioned paternalistic approaches to consultations to much more collaborative and shared decision-making discussions. So patients involved in the study have talked about the fact that it has helped them to feel more engaged with their care, and it's actually they've reported that it has improved their concordance with medication because they feel that they're a trusted part of the clinical relationship and therefore they're more likely to carry out the things that were agreed in the consultation. Other patients talk about it helping them to understand their disease, their conditions. It can help to avoid confusion, and it can also help to make the relationship with GPs better because it avoids GPs being asked to translate communications from secondary care that patients might not otherwise have understood. Yeah, so this is a really understandable concern of colleagues when they're thinking this might be a good idea, but they're worried because we're all overworked and overstretched. And so the additional cognitive load to change what is a very deep-rooted practice for many of us, if we trained some years ago, it's actually much easier than you might think. We are used to tailoring our verbal communication to patients depending on their literacy when they're in the consultation room. Doing this on paper is just merely an extension of that. And actually, once you start to get some key phrases around the fact that this is a summary of the consultation, we discuss these key points, then it becomes second nature. And the benefit of changing the way that you write in the letter is that you're then much better able to explain complicated concepts that we have to try to communicate to our patients in clinic. It makes that much easier when we're doing things verbally as well. Really importantly, once you are used to it and once you're practiced, it definitely doesn't take longer than writing a letter to the GP. And that's a common concern that people who write to GPs and don't yet want to change their practice bring to us. And we can reassure that it is just as quick if you write to the patient instead. So we ran a workshop that wasn't part of this research itself, but ran alongside because we recognised the importance of getting the opinions of primary care colleagues who we weren't able to include in the study because of the scope limitations. Really interesting to me, in that workshop, we learned that many GPs never actually read the clinic letters that we send. So 20 to 30 years ago, there would be an exchange between a GP and a secondary care physician. We might know each other. We might use that opportunity to communicate important social things about the patient, and we might use it to educate each other about different aspects of our specialisms that would be beneficial, not just in relation to that patient, but for wider kind of clinical education. Those opportunities have changed completely now. When letters are sent to the GP surgery, they are often managed by administrative staff who are well trained in being able to pick out the key messages and actions for GP practices. Those actions often relate to medication, and so that those actions might go to pharmacists. So a lot of the time, these letters don't actually touch GPs. In our research, many participants who expressed anxiety about changing practice were worried about the way that this might affect their relationship with GPs. For example, is it rude of me to write to the patient when it was actually the GP that referred them to me? And because of our finding that often the GPs aren't making contact with the letters, I think that we can really reassure colleagues that GPs are not going to be offended. In addition, we know that GPs are often asked to translate the content of clinic letters where the patient has been unable to understand what we're saying. And also, if we use three-letter acronyms, there might be the same three-letter acronym used across a number of different specialisms, and GPs may not be familiar with them because they have such a broad scope of work. So actually, writing in plain English to patients may help to reduce GP workload. So the top 5 practical tips in writing to patients would be to think about the reading age of that individual. The kind of average national reading age is of an 11-year-old, and clearly you need to tailor that to the patient as you would your verbal communication skills in clinic. We found that patients really do want us to use the medical terminology. They need that to be included in the letter so that they can understand what is being said about them, and so that it's clear to patients and their other healthcare providers what the matter is. If you use that medical terminology, please then explain it. You can explain it in the clinic setting, and you can explain it in the letter, for example, with brackets or a brief explanation afterwards. We recommend not using terms that could be pejorative or judgmental, like this delightful 73-year-old lady. These are often gendered, more likely to be judgmental about whether a woman was nice than a man was nice. And some patients find them to be offensive and judgmental, and it actually interferes with their perception of how the interaction with a clinician has gone. The fourth and related point would be to try to replace words which could be regarded as judgmental or offensive. For example, somebody denied smoking, somebody admitted drinking alcohol. These come with value judgments about whether or not those things should or shouldn't be done. Instead, you can say, we discussed that you smoke, you shared that you drink alcohol. It's the same information, it's factual, and it comes without that judgment that might make patients feel uncomfortable. The final and really important key tip is to keep the clinical impression clear. The, the main reason for seeing a patient is to make a clinical judgment and some recommendations about treatment. If that message is lost, then you lose the whole purpose of the consultation. Sometimes we do need to use technical terms, or we need to rationalise why we're making a certain clinical judgment. And if that's necessary, that's fine. Patients do want to have good clinical care, and they don't want us to trip over ourselves trying to use only a reading age of 11 that might then get in the way of that kind of clear clinical impression. I think the main thing is just to have a go. Nothing bad is going to happen as a result of you trying this, and you can always flip back depending on how you find it. Our advice to people who already write their results letters to patients, which is many more than write directly to patients in terms of their clinical consultations, is to build on that work that you're already doing. We would recommend starting with simpler consultations and for patients that you know well. So you could even say to a long-term follow-up patient, I'm trying this new thing out. If it doesn't quite work for you, please let me know. Or, if you don't necessarily want their feedback, then seek forgiveness. And we would also suggest seeking feedback formally and informally. The resources that we've developed have a feedback form that you can give to patients that will enable you to collect evidence for your appraisal or portfolio, and also to understand how the change in practice has impacted on them. It's also really worth just asking your colleagues who might have to read your clinic letters for their opinion. I received some really useful feedback quite early on when I'd adopted this practice, that the clinical summary that I was writing wasn't really so clear to colleagues, so they weren't quite sure of my reasoning. I've subsequently changed that and haven't had any questions around what exactly I meant in the letter, and I think that's made things much clearer overall. So try to do it with patients who you feel comfortable with simpler consultations, and follow-up patients would be my key tips for getting started. Thanks very much indeed for listening so far. The final things I wanted to do was just signpost to a couple of things that might help to get you started in writing to patients. The first is a set of resources that we've developed with patients and the multidisciplinary team through this work to help healthcare professionals to get started. Those resources are freely available on the BSR website. They include example paragraphs where you can compare a letter written to the patient and to the GP, more writing tips than I've been able to cover just now, a recommended clinic letter structure, an example script for discussing written letters to patients, because sometimes they need encouragement to read those letters and engage with them, a feedback form so that patients could give you feedback about whether or not they have found your letters accessible, a really helpful, I hope, phrase book, which we've developed to help healthcare professionals find plain English terminology to use in letters, and a useful list of terms and phrases, including things like we discussed, you shared. We also have some patient-facing resources, and that includes a glossary of terms, which is the same as the list of terms that I alluded to before, but just presented in a way that was felt to be more accessible for patients. You can dip into those resources as and when you need, or you can read them as an overall document. And they also include some testimonials from patients and healthcare professionals around why they think writing directly to patients has been helpful. Finally, we have a session at conference on the Tuesday at 3:55 in the afternoon. It's entitled Engaging Patients and Improving Communication in Rheumatology Services. We've got some brilliant speakers, and we will also have hard copies of the resources to share with you then. Thank you.